Great, thank you. So these are intended to be framing remarks. So we have one more input, and then we're going to break loose, and conversation's going to break out across the room. So can I ask Jerry and Ashish and Paul to, because we're going to have a chance to break out in small groups and talk about all these. But so next we're going to hear about data.
Well, data will definitely keep us awake for the next hour or so. So this presentation is really a team effort. Claudia, who's listed here, is a postdoc who works for me, but really this is funded by the Commonwealth Fund, and instead of just funding it, they've actually very actively participated in the design. So Melinda and others have been very involved in this project. My job today is sort of introduce the whole topic of data. What does the existing data look like? And then cover a few topics that people like Ashish aren't able to do because he is working mostly with claims data and I'm working with other sets of data as well. So I want to try to do that. But just all of you are not academics, so let me just give you a brief history of the academic literature. We spent a lot of time talking about who are the high-cost people, very well known. You all are familiar with the 80-20 rule. And in the academic world, we've essentially tried to base this on claims data, or we've based it upon more comprehensive data sets. We've had different thresholds, 1%, 10%, 20%. We've had dollar thresholds. We've looked at 1 year, 2 years, 3 years. We've sometimes included long-term services and support. Sometimes we haven't. Sometimes we've included social services like housing and transportation and who are these high-cost people, and sometimes we haven't. We've done it by demographics. We've done it for specific diseases, lots of studies by specific diseases. We've looked at people with multiple chronic conditions. One of the studies that I did like 20 years ago now showed that 2/3 of Medicare spending is by people with 5 or more chronic conditions. We've looked at ADLs and IADLs, how many count, what's the level of impairment, what's the level of disability, how do you define these things. This is a study that I did with Jim Nickman back in 2001 using 1996 data. The numbers haven't changed all that much. I can show you this. This is in your slide presentation. I won't go over it. But what we haven't done in the academic community very much, we've looked a lot with the high-cost people, and we've got risk adjusters for this. So CMS has all sorts of work on risk adjusters. And we heard earlier today all about targeting and who are these people that need most attention in the high-cost community. But what we haven't done is very much in the high-need community. If you look at the literature on who are the high-need people as opposed to the high-cost people, we really have very sparse literature. Not all high-need people are high-cost. Not all high-cost people are high-need. It might depend on the framework. So, as part of trying to figure out who are these high-need people, we had a lot of discussions with lots of different people. And what we were trying to figure out, what were the attributes that caused somebody to be a high-need person, not necessarily a high-cost person. And so there's a number of things that we looked at. One is the severity of the condition or the severity of the functional limitation. So if you had one really bad thing wrong with you, did that make you a high-need person? Is something like end-stage renal disease just automatically puts you in the high-need category? And then the second thing is, everybody says, well, yes, but this person's very severely ill. Well, how do we define severity of illness? And that turns out to be something that we don't have a really good handle on, especially if we're looking with claims data. And then multiple chronic conditions. Well, how many is too many? How many is multiple? Is it 2? Is it 4? Is it 6? What is it? What makes a unique chronic condition when we're trying to look at all this data? Is type 1 and type 2 diabetes a different disease, or is it the same disease? And when you're playing with all this data, these are all important issues. In terms of functional limitation, does having one IADL allow you to be a severely ill, a high need person or not. And then you have the issue of disabilities, which if you look at Social Security, they have a work-related, workers' comp, have a work-related definition of disability. Is that what we mean in this set of activities or not? So we start looking at those. And then you have the whole issue of behavioral and mental health. And essentially, is mental health, and some people say it's just a simple chronic condition like everything else, and other people say no, it modifies, it makes it so much difficult to deal with the diabetes or something else that it's in fact a separate category as well. And then we heard all about, from Darcel and others, about the social needs as well. So as somebody who's trying to put these numbers together, these are all issues that we have to essentially deal with. So I'm going to show you something, the simplest model that we have. I know Ashish has got a lot more complex models, and I'll let him go over those. So we essentially chose, and I want to present to you just one model, because I want to talk about other things for a moment, and essentially one definition of high need, and that is conditions that are permanent, somebody who has 3 or more chronic conditions, and a functional limitation and or a disability. So you're either yes or no in these kinds of things. And then we'll just break it out for mental illness, behavioral health, and non-behavioral health. We absolutely recognize there's lots of gradations here, lots of different ways to do the typology, but in trying to get this presentation to make sense, I've just done it into yes or no. So I'll go over this one really quickly because I really want to go into some of the other issues. One is, this is who in the adult population, not the children, but in the adult, is the high need, high cost person. And they're obviously they're older, they're poorer. And I'm going to keep coming back to that. So if we look at who they are with and without behavioral health problems, they're more likely to be female. Not surprising, because women tend to live a little bit longer. Obviously, they tend to be older. A little bit surprising, they tend to be more white than non-white in terms of who the people are in this definition of who's a high need person. You basically, if you don't go to school, if you don't go to high school, you're more likely to be a high need person. If you go to college, another benefit of going to college is, you're much less likely to do this. It's all socioeconomic determinants of health. If you're privately insured, and we heard a number of people in privately insured programs just earlier today, there's not nearly as many of them in the private insurance market as there are in the Medicare and Medicaid program. And the uninsured don't tend to be very highly in this high need, high cost population. The thing that I find the most interesting, though, is this slide. And that is essentially, this is using MEPS data. And so they tend to underestimate expenditures for a variety of reasons, which I won't go into. But essentially what we have is about $5,000, $4,500 in average health spending, and an average income of about $27,000. And so that's sort of what the American population looks like. However, if you are a high need with behavioral health, your health expenditures go up by a factor of 5 or 6, and your income goes down by a factor of 5 or 6. So, Darcel, I feel your pain. If you have high need and no behavioral health, you're going to make you're going to have even higher expenditures, and your income is going to be a little bit higher. So 17% we spend on health care. If for the general population, if you're a high need, you're spending 352% of your income on health care. If you have high need and no behavioral health, 259% of your income. This essentially is the problem that these people are having on a daily basis. Second thing is, it's always good to be rich. So essentially, healthcare spending for people who are, for across the board, the rich and the poor spend about the same amount of money on healthcare. But if you are high need and you are rich, you're going to spend significantly more than if you're high need and you're poor. So significant differences between these two groups. So we have these needs, we have access, we need to get transportation, we need to get all these things. We're spending more money if we're rich than if we're poor, because we can. But that doesn't mean that the poorer people don't need those kinds of things. In terms of outcomes, what we see is emergency room visits are obviously much higher for people with high needs. Not surprising. But if we talk about all the issues of patient-centered care, shared decision-making, some of the issues that we're going to be talking about today, for the high-need, high-cost patients, they're not getting anything different than the average population is essentially getting for these kinds of things. So we don't see much difference in that. In the academic literature, what I see is missing from this whole analysis is the whole concept of amenability to change. We have people that are high cost. We have people that are high. We're developing measures of who is high need. Changing the financing system, changing the delivery system for many of these people is probably not going to make much difference, at least for some of them. What we don't know are the characteristics of these people for whom the delivery systems, for whom the financing systems will improve their outcomes and lower their spending. What do I see in the literature, and there's not much of this, is we've got to take a look at behavioral characteristics. Some people are just not likely to change. Perfectly PC term, the old and crotchety. Essentially, they are not going to change. People with certain behavioral health concerns it's a challenge to get them changed. We don't have a good sense in a systematic way of the clinical characteristics of the diseases or the combinations of diseases that are most modifiable. Clearly, there's an interaction between the two. So what we finally need here is this sweet spot of who are the high need people, who are the high cost people, who are the people that are most amenable to change. And I don't think, at least from the academic side, that we have even a good chance of figuring out those right now. With that, Ashish, I'll turn it over to you.